allowing us the opportunity to present our complex care here at Children's Hospital, or McMaster Children's Hospital. So just to give you a little bit of background, we do have sort of a complex care team probably 20 years ago, where our first patient that is home ventilated went home 26 years ago. However, at that time, the team wasn't as formalized and organized till 2 years ago. So we are a very young team, and we have lots to learn from other more established team in other parts of Canada. So currently, we'll just introduce to you what we have. In terms of inpatient care, we have about 6, and we'll be increasing to 10 inpatient complex care patients, and these are patients who have tracheostomy, who are stable, and we're now getting more of the medically complex technology-assisted patients who may not have a tracheostomy. We have an outpatient clinic that runs so far just once a week, and we have started a fellows continuation clinic one afternoon a week as well to see follow-up patients and urgent referrals. There are consults that we do in PCCU, level 3 NICU, as well as the wards. And we have an outreach program with home and school visits that we're trying to ramp up if in the near future. So the team consists of 4 pediatricians, 2 RTs, 1 nurse practitioner, and 1 clinical nurse specialist, and currently 1 clinical fellow. Not an academic fellow, but a clinical fellow. So the population that we serve are really just a subset of technology-dependent kids, and most of our patients have tracheostomy or home mechanically ventilated, and they're medically fragile, chronic issues, and complex medical concerns. The children that we serve do not have a clear diagnosis, and majority of them are not under any subspecialty care, meaning that they are not clearly under endocrine or neurology, and most of these patients have sort of pulmonology respiratory concerns as sort of a more common part of the subgroup, just because we don't have a respirologist currently. So just to give a quick overview of the spread of patients that we have in our region. As you can see, 14 out of 64 are home mechanically ventilated, 34 are tracheostomy dependent, and we do have about 10 that are medically complex. So currently we serve about 64 patients in our region. So the regions are broken down into LIN 4, which is the LIN that we are currently in, which makes up about 70% of our population, and 24% of Waterloo, Wellington, which is we find a growing area where we're getting more referrals from, and 1 or 2 from Halton and Southwest LIN. The function of our pediatric chronic complex care team is a lot of time and I guess focus is spent on teaching and training parents and caregivers of children with trach and home ventilation and tech dependency. We are really striving for seamless care from inpatient to discharge home and the community. Currently, we are working towards more of a comprehensive discharge planning, really trying to invite the community pediatrician or family physician to be on board, which we find is an area that we really need to work on so that the care can be continued in the community. We also help our families navigate through different systems and agencies, and we provide a lot of the outpatient clinic support and telephone calls and emails as well. So our goals are to optimize the health and quality of life of the children that we currently serve, to have a coordinated, comprehensive care plan for each child, and as at the last PCMCH symposium, to have one family, one team, one key worker or a case manager, and really to work on collaboration and integration of care into the community. This is sort of a pictorial representation of our model of care. We're not there yet, for sure, with the child and the family in the center. We hope to have each child have a primary pediatrician here at MAC with a case manager and liaising with the community pediatrician, our community partners with CCAC, rehab, and school-based services, which again needs we need to really tighten the or fill in the gaps with the rehab and school-based services. Our outpatient referrals currently come from PCCU, NICU, as well as families who have moved from out of region into the city. And inpatients, we have mostly from neurosurgery, neuro-oncology, orthopedics, PCCU, as well as Gen Peds. This is sort of the growth of our complex care referrals so far since 2011. As you can see, there are many or increasing numbers of kids with tracheostomy, as well as home mechanical ventilation. So we do have an average of about one patient a month that has a tracheostomy so far. In terms of education, we are hoping to develop a curriculum for our pediatric residents. As of July, we have a junior resident and a senior resident rotating through the complex care rotation. And we are in the process of coming up with competency-based curriculum, objectives, and evaluations for the residents. We are sort of doing the same for the clinical fellow, sort of at a different level, and we have a new fellow joining us in August. As mentioned earlier, we have a fellows clinic that we're still trying to keep going with that, as we've got feedback that it is a good learning experience for the fellow, and a refresher course for parents of children with trach and home mechanical ventilation. Research projects that we've done so far, we have a study in collaboration with SICKIS with Dr. Amin, looking at developing a tool to assess caregivers' knowledge and skills with children with home mechanical ventilation. We are in the process of completing a retrospective review of our patients from 2003 to 2013, looking at length of stay, readmission rates, emerge visits, and clinic visits. We haven't had a lot of opportunities to do research in this area, and we're hoping to, hopefully with time and with more manpower, that we can do more studies in this population. Future directions is to expand our team, definitely to include children with more medical issues, without tech assistant, to build our team, and definitely to do more outreach and integration into the community. And we haven't done much work in terms of transition to adult care. So far, I guess the patients in our population are still quite young and have not been a focus of our group just yet. But I think it will become a focus soon. And also to evaluate our program in terms of parent and family satisfaction, hospital and health services utilization. That's it. Thank you.
Thank you. Great presentation. Does anyone have questions for Dr. Lim?
Hi, it's Anna Cooper. Can you just elaborate a little bit more on how you integrate with the community? So, assuming that the children, obviously go home, and the work that you do to integrate them there and to keep them at home.
So I guess
but there being outreach, is there actual that's being made by, say, nurse practitioners or somebody in the community to integrate them further?
Right. Well, the nurse practitioner is stationed here at the hospital, so they're
Right.
not able to do that piece of it. We've spoken of trying to do a bit of a roadshow out to the outlying communities, but we haven't managed. We haven't had time yet to develop that. But we do spend a lot of time. The RTs, Jeannie and Cindy, spend a lot of time educating the community nurses in preparation for children with airway issues. So they actually come into the hospital and learn directly at the bedside, as well as 2 8-hour-day education days for both trach and vent.
Mm-hmm.
And then in terms of once the children are in the home, we do home visits for the mechanical ventilation population when they first go home. And then as needed after that, as well as school visits. Once they're entering the school system, then an RT and RN partner will go out into the school to have a visit there. And we'll also attend the school meetings in preparation for the kids to be integrated into the school system.
Right.
And that's often at the request of the parents.
Mm-hmm.
So we're quite open, and we've really enjoyed that aspect of trying to, build better relationships with the community.
Mm-hmm. I wanted to just make a comment. I was at Toronto Central CCAC prior to being here at Bayshore, and it was a model that we were actually looking at and were implementing, where nurse practitioners actually were going out to the home and making visits there in the home, and having that sort of single point of contact for families. And also really giving the nurse practitioners that firsthand experience of the home setting and what parents were actually going to be working with and living with and trying to adapt and adopt as they're...
Sure, we find that part invaluable.
Absolutely, that was exactly the experience that we all had.
Yeah.
Because there was numerous nurse practitioners that said, I had no idea what it was like for these families.
Right, right.
So
Yeah. On a personal note, I thought I knew, even after doing some home visits, but it wasn't until I went on a wish trip with one of the families that I really saw what it was like to live with this kind of technology that's invaded your home.
If I could just ask one more question, too. A little bit further to that, one of the things that we struggled with when I was at CCAC is looking for ways to quantify whether this model of greater integration and more connection actually resulted in reduced unplanned merge visits. Have you guys looked at that at all yet? And if you have, how have you managed to collect that data, or has anybody else managed to actually collect that data to actually justify it and say that because of this, we are now seeing fewer unplanned emerge visits?
Right. Yeah. No. Unfortunately, we didn't, keep a database right from the start to quantify, how many of our telephone calls or home visits actually stopped them from, coming back into hospital.
Right. Okay.
So no, unfortunately, we haven't collected that data.
Well, and I think we found, and others, my understanding, others have found it's very difficult to sort out how we would find that.
Yes.
But if we could, wouldn't it be great?
It would be great.
Mm-hmm.
Yeah,
Thank you.
It is very challenging to measure this, just because you have to take the child, look at before and after, and if they have a brand new change in their mechanical ventilation, it's hard to compare.
Yeah, it is very difficult to collect.
Mm-hmm. I have a question. It's Natalie from Ottawa regarding the funding of your program and how does it work?
Yeah, good question, Natalie. We don't have any funding. The pediatricians are, which is, how do you call those? Not fee for service, but we have, I'm running out of the word. it's just part of the division. So there's no funding separate funding for our team.
Okay.
Yeah.
So the RTs, the nurse practitioner, are part of the respiratory team that looks after trach. Would it be under this umbrella?
Yes, yeah, our salaries are just hospital-based, and we're all each under specific programs.
Yeah.
Okay.
We currently don't have a respirologist, so the hopefully soon we will be having a respirologist studying with us. So it may look a bit different in terms of the patients that will come under our team. Yeah.
We've borrowed from the adult world in terms of consults and managing some of the long-term ventilation.
Okay.
Oh,
and
hi.
our allied health, our other allied health members are just in kind from the ward or from other clinics. So there's definitely recognition that we need social work and dietitian and OT, PT, you know, as members of the team, but right now it's definitely all in kind.
Hi, it's Julie Fisher. I just had a question about your comment about no pediatric respirologist. Is that that there's no pediatric respirologist at McMaster at all?
Correct, yeah. So we do have an adult respirologist that used to work in our pediatric intensive care unit that is kind enough to help us with some consults and do a follow-up in the home ventilation clinic. Yeah, so we will be getting a respirologist in August. And that will be, yes, a landmark.
And that's a pediatric respirologist?
Correct. That will be a pediatric respirologist, and we're really looking forward to that.
Yeah, I can't even imagine that, because at our center we probably, gosh, we must be at least 5 or 6 pediatric respirologists, and so it really sounds like you're running the pediatric respirology service, which would be in our model here with the home ventilators and the tracheostomies and such.
Right.
Yeah, correct.
Okay. Any other questions?
Hi, it's Gail Bonin from Winnipeg. Can you guys hear me?
Yeah, go ahead.
Okay. I was just wondering, one of the things we're experiencing here in Winnipeg right now is the ongoing of supports for the family and training, especially when they're medically complex with trachs and ventilators, and that is probably like everywhere else where you have limited respite from nurses. And once we discharge them, a certain number of people are trained. Like everything else, people come and go into people's lives. And how do you necessarily manage the ongoing training of lay people that enter into these people's lives to help provide support that weren't previously trained?
Hi, it's Jeannie. Well, we hope to hear from the families, and anytime they do have any new family members, lay people, we support them by having them come in for classroom training. We support them in clinics. We support them if the child's still in the hospital. But we continue to offer support at any time for them.
Oh yeah, but the RTs are training new people constantly.
And that is a problem.
It is a real
because they
problem.
can't provide, yeah, it's, and it's hard for the families as well.
How do you observe the people doing the skills? Because I know usually when we do it, we can do the classroom, but our issue is the ongoing observation and not having a space once they're actually discharged. And I guess because we don't have anybody going into the homes and doing home visits, it's a challenge also.
Oh, so yeah, what we do, of course, in the classroom, we have the mannequins, and then we've recently, well, in the past couple of years, we've introduced high-fidelity simulation, which has really helped with our observation of the skills of the learners. The other thing is we also ask the new caregivers that are learning to actually come into clinic with the actual patient, so we can observe them doing tracheostomy tube changes at that time. And we do ask for families to not leave the new trained caregivers until they're completely trained.
Okay.
And then we've also gone into the home as
We've
well
gone, absolutely, yes.
to observe the trait changes and further
And
education.
ventilator assessment, yes.
Okay. Great.
Okay. And it's Natalie again. I actually will have to excuse myself. I've just been called. So, Lisa, you okay to take over?
Certainly.
Okay. Thank you.
Thanks.
Thank you very much, Dr. Lim and Joanne and your team for giving us this presentation. This is always very nice to hear about how do other programs make it work. Thanks.
Thank you for the opportunity.
Yeah. So, are there any other questions or comments for the McMaster team? Sounds like you're doing an awful lot with some sort of limitations that are put on you by a system. But
Thanks, Lisa.
I just had one more question, if that's okay. I know you'd mentioned that as of this July, you're going to have one junior and one senior pediatric resident joining the team. Will that be for the full year, or is that on and off basis?
I think as for the coming juniors, we do have enough from what our program director, residency program director has said, that there will be enough junior residents to have someone on each month.
Okay.
Oh, sorry. The juniors are only coming on for 2 weeks.
Gotcha. Okay.
And the seniors are coming on for a month. And now that we have a new respirologist starting, it may be a combined complex care respirology rotation.
Right. Okay. Okay. But you might not have senior pediatric residents every month, just some months. Is that correct?
Correct.
Okay.
Correct. Yes.
Is that a mandatory rotation, or is that a elective?
Right now, it's been rostered into their rotations.
Right. So it's mandatory.
Okay. We're starting this July.
Perfect. Great. Thanks so much for your help, and thanks for your answering the questions, and thanks for your great presentation.
No problem. Thank you.